All right, we are now live. Hi, everyone. My name is Tim McMahon. I'm the Director of Marketing here at St. Joseph Hospital in Nashua. And on today's Facebook Live, I have with me Dr. Andrew Garber. Dr. Andrew Garber is a orthopedic surgeon here at the hospital, along with New Hampshire Orthopedic Center. And today we are going to be talking to Dr. Garber about St. Joseph Hospital's recent certification as a DNV hip and knee certified hospital. So we're going to start with why that's important, what that means to the hospital and our patients. And then afterwards, we're going to talk a little more with Dr. Garber about some of those common questions patients ask him about hip and knee surgeries. So welcome, Dr. Garber. Thank you for being here today.
Yeah, thanks
And
for having me.
like I said, let's just jump right into it. So DNV certification, hip and knee certification, what does that mean? Why is it important?
Yeah, so the DNV certificate, it's a national organization that goes and looks at hospitals and surgical facilities to make sure that basically they're doing the things they should be doing and to track the data and outcomes and just kind of give you some confidence that where you're going to have these surgeries done is going to be somewhere that has put the work in and has the infrastructure in place. So we started this probably just over 2 years ago, I think, was the process of getting certified there. I'm the medical director of the hip and knee replacement program at St. Joe's. So being a part of that and just seeing it start from the ground up, there's been a ton of work and honestly more so from the staff side than from me. I've just kind of been helping with the medical side, but making sure that we have the ability to track our patients' outcomes, making sure that we have the proper sterility processes in place, making sure that the preoperative assessments and things to make sure that patients are optimized and that they're not being taken to surgery when they're not medically optimized, to make sure that it's safe for them, making sure that their therapy protocols are in place and order set. So there's a huge infrastructure process to make sure that all that's in place. And the DNV basically is a third party to assess that and make sure that across the board from here to other hospitals that we are, at least up to par, but really excelling, trying to make it a center of excellence to do hip and knee replacements.
That's great. Thank you. Now, as far as you know, are there other hospitals in the area in southern New Hampshire, Massachusetts, that have this same accreditation?
So there's only two, to my knowledge, in the area. One is here, and then the other one is Elliott up in Manchester. But I think in this area of all the places that we go, there's only two in this area that have been accredited for hip and knee replacements.
That's fantastic. Yeah, that I know we're really excited as a hospital to achieve that level of certification. And as you said, it sounds like it really does result in better outcomes for our patients.
Yeah, I mean, I think anybody that's involved in the process and the surgeons who operate there would tell you that just in the short term since last summer that we received the accreditation, that just seeing the improvement and the staff that have kind of invested their time and efforts, and they really have taken some personal, feelings and personal investment in trying to make it a better process and make it a place that patients want to go to have these done because they know that we've put in the work to make sure that it's done appropriately. It's really made a big difference just in that short period of time.
Yeah, absolutely. Well, we really want to talk about the DNV and certainly why that's important. But since we have you here, we also kind of wanted to learn more about you and the types of procedures you do here at the hospital. And we know we have a lot of questions that patients often ask us about surgery, about knee surgeries, about hip surgeries. And we just thought, hey, this is a great opportunity to, talk to the expert and get those questions answered. So first off, I know you said you're medical director for the Hip and Knee Center Replacement Center. Tell our audience, more about the types of procedures that you typically do here at the hospital.
Yeah, so I mean, I primarily specialize with hips and knees, mostly with arthroplasty, so total joint replacements, partial knee replacements, things like that. I do some trauma cases with hip fractures. A big part of my practice in particular is revision surgery, so patients who've had previous joint replacements who have complications, whether that be infections or fractures, loosening of implants, or just honestly, a lot of patients who have them done have pain afterwards, and especially ones that have been done 10, 15, 20 years ago. Parts can wear out that need to be changed. So a big part of my practice is doing what are called revisions or redos of those surgeries. So at almost all of my first time knee replacements now are done with the Mako robot, which we now have at St. Joe's. So it's a more it's a more precise way of doing total knees, and the outcomes are starting to show that too, that your range of motion is better early on, and the outcomes long term are looking like they're going to be better as well. But I also do primarily anterior hip replacements on anybody that I can. Sometimes it's safer to do those through the traditional posterior approach, but the anterior approach is big for me, and then revisions. So those are the three main things that I do there.
So since you mentioned the Mako robot, remind our audience, what is the difference between using the Mako robot for a total knee replacement versus not using the robot?
Yeah, so I mean, the surgery process is fairly similar as far as the incision, the approach to the knee, things like that are very similar. The traditional or the manual way of doing a total knee is based off of jigs that you place on the bones that are basically put where I think they are fit best. So you size the knee in the operating room, you position these jigs to make the preparation of the bone or the cuts of the bone, but it's all intraoperative. So there's some subjectivity, there's some room for error, things like that. The Mako is based off of a preoperative CT scan that you get done. So the implants are not made for the patient. That's another big question I get. They're not customized to the patient, but we're more customizing the process to that patient to make sure that it's accurately sized, accurately positioned. And then when I balance the knee in the operating room, instead of manually or subjectively thinking, yes, this feels about right on both sides, I'm getting real data and numbers to tell me 2 millimeters here, 2 millimeters here, things like that to make sure. And then if I need to make those adjustments, I can change the plan. And then when I'm making those proposed bony preparations, I can actually plan for take 1 more millimeter here. And it's not just me eyeballing it and rough estimate. It's precise things. So it's a more precise way to do the same procedure that's been done, but that's where there's always room for improvement. So technology typically is going to be better than what I can do on my own.
Sure. Now, I think most people would want to know, does it improve recovery time? Because I think people think knee replacements, that's probably a long recovery.
Right. Yeah. I mean, it does. That's where a lot of the early data is showing, is that the range of motion, patients get their range of motion back faster after robotic knees compared to traditional manual total knees. Now, surgeons who do all manual or partial manual, they will say, well, I have patients that do great. And I said, well, I agree. But I think there's also any surgeon who tells you every patient does amazing is not telling the truth. So there's always room for improvement. There are always ways to improve what we do. And it's certainly not any worse, but if it's has the potential to be better and it's more precise, I think it's a good idea.
Now, typically with a knee replacement, especially using a robot, is that something where you would stay overnight, or is that a go home the same day type of thing?
It can be both. It's patient dependent. So if your health allows, meaning you don't have any significant cardiac history, uncontrolled diabetes, things like that, then a lot of patients could go home the same day. What I tell my patients is just be honest with yourself about how you handle anxiety and pain, and if you know yourself better than I do. So if you're someone who gets concerned if something changes or if your pain starts to kick up a notch after the surgery, I usually recommend that patients stay 1 night in the hospital. But if you're somebody who understands and just kind of says, I go with the flow, I know it'll get better with my pain medication that I can take at home, a lot of patients prefer to be in their own beds at night.
Absolutely. So since you mentioned pain medication, what are you typically prescribing for post-surgery? Is it, you hear a lot about opioids, trying to lessen opioids. What do you usually recommend?
Yeah, so a big piece of this now is it's actually from the anesthesia side. So they've changed their protocols now to try this multimodal pain management. So instead of just giving everybody narcotics and that's how we control pain, now we're trying to do that with nerve blocks and with nerve pain medication and with early mobilization to get patients up moving sooner to decrease stiffness, things like that. So most patients do need some short period of time where they're taking opioids or narcotics afterwards. I have some patients who get by with nothing but Tylenol, and some patients that end up needing to be on some medication for 6 or 8 weeks, weaning down after that, and then everywhere in between. So most patients will go home with some form of a narcotic based on their medical history and their other medications. But Tylenol is used with everyone who's allowed to have it and doesn't have a medical reason not to. But then the nerve blocks, and typically the surgery is done under a spinal, which helps a lot with pain control as well.
Is the nerve block, is that a newer thing? Is that something, if you got a knee replaced 10 years ago, 15 years ago, were they doing nerve blocks at that point?
Probably about 10 years ago is when it started getting a lot more popular. But the difference is that the older nerve block was a femoral nerve block, where they actually went way up high close to the groin, and the whole leg was then numb and the quadricep muscle didn't function. So patients couldn't ambulate as quickly. They had to wear a brace when they tried to walk for the first couple of days. Now the nerve block that's done are much more localized to the knee. So it's only sensation or cutaneous nerve blocks. So you're able to get up and walk right away. The muscles are working normally afterwards. So it's been probably around that 10 to 15 year range that we've been using nerve blocks, but what nerves are blocked and how they do them have changed.
And I think that's really important for our viewers who, maybe they got a knee replacement in the left knee, 15 years ago, and now their right knee is kind of going, and they're hoping for a different outcome, hoping for a better situation. So I think that's great. Thank you.
Right. Yeah, the utilization of spinals has helped a lot too. So a lot of patients hear spinals and they cringe because they either have heard about epidurals or things with childbirth or otherwise, or they've just had a bad experience in the past. Other patients assume that if you have a spinal, you're going to be awake during the surgery, which is also not the case. So the typical routine is to have the spinal done just to control, so you can't feel anything during the surgery, and then they sedate patients. The anesthesiologist sedates the patient, kind of like a colonoscopy, so that they're sleeping, but they're not so asleep that their respiratory drive stops and they have to be intubated. So most patients are able to have these done without a breathing tube or having to go on a ventilator.
That's great. Now another question we hear, again, when we're comparing, today's replacements to replacements 10, 15 years ago, how long do they last? So is the technology better? So a replacement knee today, is it lasting longer than it was 10 plus years ago?
Yeah, well, so I mean that's another goal of the Mako, is that by more accurately positioning the implants, that you're not going to get this, unnecessary increased wear of the pieces. So if you don't align things properly, or if there's little edge loading or things where that could have been positioned better, you're going to wear that out faster. So that's one benefit of that. The other from a product standpoint is the plastic liner that goes between the two metal pieces. It's called the polyethylene insert. That technology has improved significantly, so the wear rates are much lower. So they're predicting that it's going to be somewhere between 25 and 30 years, whereas the older version, meaning 15 plus years ago, probably was 10 to 15. I see patients that are 21, 22 years out, and they have the older version and they look fine. So, I think a big part of this is how it's put in. The patient's size obviously plays a big role in this. The more force through the implants, the more likely they are to wear out. The more active the patients are can play into that. So there's a lot of factors that play into that.
Okay. Now you mentioned you do a lot of revisions. Mm-hmm. So I guess my question would be, how would someone know they need a revision as opposed to a complete replacement?
Well, so a revision could be a revision of one piece, or it could be of the whole thing. So if the main symptoms of failure, or the main symptoms that I see when patients come in and they say, I had my knee replaced and it was supposed to fix my pain, but I either still have pain or I was okay for a little while and now I'm having pain again. A lot of times it's not the implants or things that have to be changed. It can be the soft tissues around the knee, the IT band, any tendons, ligaments, things like that. But from a how to diagnose that would basically be to get an X-ray. But pain is the main symptom that patients would have if they were having something that were failing. Like I said, infection is always on the back of our minds to make sure that that's not something that's creeping in. But usually there's a reason if you're going to have an infection or something like that. But it's really pain or instability is the other symptom I hear a lot.
So certainly recommending that if someone's had a knee replacement at any point really in the past and they start feeling pain in any part of their knee, that's a opportunity to maybe come talk to you and say, hey, maybe something's not quite right here.
Right. Well, and it's not always surgical either. So a lot of patients come in and they've assumed, oh man, I'm going to have this thing redone, and it's not always that. So, but there are also certain things where if you find them early, it's a lot easier to fix than if it goes on for years and years and then it creates other problems. So yeah, if you've had joint replacements done in the past and you did well for some period of time and now it's hurting again, it's usually a good idea to have that checked out.
Great. That's great advice. Don't wait.
Yeah.
Well, hey, we're almost about at our time here. So, Dr. Garber, is there anything else you'd like to share with our audience about knee replacements? We haven't really even talked about hip replacements. That you would like people to know.
Well, I mean, just in general, a lot of the questions that I get about, when is the time to do it? Is there an age group or an age bracket that I should wait until I get to? And the answer to that is really no. I mean, everything is patient dependent. So patients who've just started having pain typically are not going to be having a joint replacement anytime soon. It's typically something where you want to try some of these conservative treatments first, try to see if we can get your pain under control. But the normal age of having joint replacements has come down significantly. I mean, it used to be wait as long as possible, and that's the last thing you want to do. A lot of the discussions I have now in the office are about quality of life. So a lot of my 40s and 50s and 60-year-olds who say, well, I don't want to wait till I'm 80 because I want to enjoy the next 15, 20 years of my life instead of suffering through that, which I think is reasonable. And especially as our implants and our techniques are improving, I think we're more able to give them that for that period of time, even if it means they may need another surgery 20 years later to replace whatever part may wear out. So it's not something anybody wants to do. It's not a fun process for patients to go through, but it makes a big difference.
Great. Well, Dr. Garber, thank you again. We appreciate having you here. We know you're busy. We know you have surgeries to get to, but again, thanks for being here. Thanks for telling our patients and our audience just all about knee surgeries and the Mako robot and the DNV certification. It's great information. And for everyone watching, thanks for joining us. We hope to see you next time.
Yeah.
All right. Thanks everyone.
Appreciate it.